Hello and welcome. Thank you for joining our patient education webinar. I am Catherine Mazurkevich. I am patient advocate for paraganglioma pheochromocytoma. I'll tell you a little bit about my story. So in 2017, after a few years of symptoms, which included some hearing loss, fainting, and really bad headaches, I was sent in for an MRI and I was diagnosed with paragangliomas. I had multiple bilateral tumors in my head and my neck. And due to the specific presentation, they thought it was likely that I may have a genetic component. So I was sent to a genetic counselor for genetic testing. At that point, it was identified that I had an SDHB gene defect. And at the time, I didn't really know a lot about what that meant. And I knew I would have to seek out having my family tested potentially, and that it would play into a little bit about the treatment and the care that I received. I am here today with Samantha Greenberg, who is a genetic counselor, and I will introduce her in a moment. But first, I just wanted to say that this is brought to you by the Pheo Alliance. Their mission is to empower patients with pheochromocytoma and paraganglioma, their families and medical professionals through advocacy, education, a global community of support, while helping to advance research that accelerates treatments and cures. And I just want to take a second to say a special thank you to Progenics, who made this webinar possible through an educational grant. Just a reminder, if you're interested, to sign up for our e-news and make sure you follow us on social media at Pheo. This webinar is actually the first of a two-part series. The second part of the series will be on January 13th at 10 and 1 Eastern time. And that portion will be discussing the family genetic angle of this. I wanted to remind you to please join our patient hangouts on Zoom. They're the first Tuesday of every month. Each meeting focuses on a different topic, and the link to register will be in the chat functionality. For today's agenda, we will be having Samantha present for about 25 minutes, and then afterwards we'll open it up for a Q&A with everybody else. Some questions have actually been submitted beforehand. We'll also ask questions which you can submit online in the chat function. Questions that are less case specific are really appreciated. Keep in mind that Samantha is not able to actually give medical advice. Her expertise is actually in genetic counseling. The information that will be provided in this webinar is for educational purposes only and should not take substitute for the advice of your doctor or medical team, because they have an in-depth knowledge of your specific medical history and your situation. Okay, with that, I would like to introduce you, Samantha. Samantha Greenberg is a genetic counselor at the Huntsman Cancer Institute. She received her master's from the University of Michigan for genetic counseling and public health, actually after teaching 7th grade in Tulsa, Oklahoma. Samantha oversees the SDHX paraganglioma clinic and a high-risk prostate clinic at HCI, alongside a multidisciplinary team. Her research and interests center around prostate cancer, paraganglioma, pheochromocytoma, and education, where she serves as a faculty member with the University of Utah Genetic Counseling Program. I want to turn it over now to Samantha. Thank you.
Okay. Thanks, everyone. I'm really excited to be here today and be speaking in the first of this two-part series. I'm going to start by just doing a brief overview. So we're going to walk through kind of what we mean when we talk about having a mutation or a positive test result, and then what that means for people in particular and how we think about family. And then we're going to end by talking about just some common challenges once we learn that we have a genetic mutation and what that means for us. I want to get us all on the same page. I know I'm preaching to the choir here. When we think about pheochromocytoma and paraganglioma, this is a figure I often talk about with patients. And for those of you on the call who may not have a tumor but have a genetic risk for these tumors, I want to again just make sure we're kind of all on the same page. So these tumors arise from our sympathetic and parasympathetic nervous system, or neuroendocrine tissue that's in kind of that green chain you see here on the left. The chain really starts kind of back behind the ears on both sides, comes all the way down below the bladder. And what you see highlighted in red are all the areas along that chain that paragangliomas can develop. Now, pheochromocytomas are a type of paraganglioma that occur in the adrenal medulla, which is in the adrenal glands. And you can see in that figure on the right, some other areas highlighted in red where we can see head and neck paragangliomas in the carotid, in the glomus area. as well as other head and neck areas. Now, when we think about genetics and paragangliomas, we think about Pheopara importantly because approximately 40% of these tumors are hereditary. And I'm not going to be speaking too much about the hereditary conditions specifically, but because there's already been a webinar on that. And I would direct you to Dr. Lauren Fishbein's webinar on the genetics of Pheopara, where she goes a little bit more in depth into each of these conditions. Here on the right, you'll see a graph just showing the time and the discovery of these genes. Notably, these are all associated with pheochromocytomas. And then when we think about paragangliomas, right, the broader tumor type, we're specifically thinking a little bit more about the SDH genes that I've highlighted here. Now, I want to walk a little bit through genetics 101, and I'm going to use an analogy that I typically talk about with our patients to think about what we're doing when we do genetic testing and when we talk about having a genetic mutation. So in this setting, we think about our genome, and I consider this to be a cookbook. And our cookbook of our genetic code has 22,000 recipes. And when we think about recipes, these are the genes that make up who we are. And these genes code for who we are and how our body functions. It codes for how tall we are, how our body fights against cancer, how we regulate ourselves. All of these things are made up of those within those 22,000 genes. And genes are composed of DNA. Or spelling, genetic code, if we think again like the recipe, right? Each line of that recipe is similar to our DNA. It gives instructions to our bodies to make proteins. And in this case, if we continue the analogy, just like our body, the genetic code makes proteins, here, the recipe, you end up with cookies. But if we think about genetic test results, we know that a few different things can happen. The first test result that we can get is a negative test result, which means they look at the genetic code in our body, nothing is misspelled, there are no chunks added or missing, and so we think that the body is able to make proteins just like it should to prevent us from developing tumors. And we consider this to be a negative test result. Now, the other scenario that we can end up with is that there's a misspelling or a genetic change in our code. And as a result, our body isn't necessarily able, I'm going to click. Sorry, I'm having just a little, the animations are running a little bit slower. But in this scenario, we see that there's a misspelling. Therefore, the body isn't able to create those proteins. And we end up with a positive test result and an increased risk for parapheo. In this setting, when we see a positive test result, we also know, that this is what we consider what it means to have a genetic mutation, or that somebody has an increased risk for these tumors. Now, the other type of test result you can get is what we see here in the middle, where we see a genetic change, but it's not necessarily a positive test result because we don't know if the genetic code creates proteins like it's supposed to, which would be closer to a negative test result, or whether that genetic change kind of impacts the body's ability to make proteins that might put us at increased risk for Pheopara. This is what we call a variant of uncertain significance. And in this setting, you'd think when you hear the word uncertain that that genetic test result could go either way, positive or negative. And while that is true, we know that research has shown us over 90% of the time, these genetic changes are often something that just makes us who we are. And we treat these uncertain test results like a negative until proven otherwise, because we know most of the time they turn out to be. And we don't want to be over screening or over treating somebody for that kind of small chance that it could be positive. So therefore, we treat uncertain results more like negatives. So all of that aside, I'm going to go into talking a little bit about positive genetic test results and thinking about having a genetic mutation and what we do next. And I'm going to break this up into 3 different topics. So when we have a positive genetic test result, it can impact one of 3 things: treatment, other cancer or tumor risk monitoring, and family members. And I'm going to walk through them in that order by starting with treatment. So if you have a diagnosis of Pheopara, talking with your care team would be a great start to see how that genetic mutation might impact treatment. Sometimes it does, and sometimes it doesn't. And this can change based on genetic testing, but is also highly variable by patient and situation. As Catherine talked about before, everybody's different. And so being able to provide any kind of medical advice based on this isn't really possible, but is worth noting that there's a wide range of options that can be impacted by genetic testing. I want to just talk about a quick study here that showed the benefits of why we do testing in relation to treatment. This is a study that came out about a year ago. They are looking at people who had mutations in SDHB, C, and D, or the VHL genes, and then they broke them up into 2 categories. The first is the genetic group, and they had their genetic testing and their diagnosis done within a year of their Pheopara diagnosis. And then the other group is the historic group. They had their genetic testing done more than a year out from their time of diagnosis, and they compared these groups to see what their treatment and outcomes looked like. What they found is that the genetic group, again, this is the group that had their genetic testing and mutation identification within a year of tumor diagnosis, they had better follow-up with more exams and follow-ups. And a lot of that is because they knew that there was higher risk potentially for other tumors in this group, whereas in the historic group, they may have just been following the tumor that they had previously seen because they didn't have the genetic testing to suggest there were other tumors that could develop. As a result, the genetic group also had less severe disease because they were able to find new tumors earlier and ultimately smaller, which means that patients were less likely to have metastasis and ultimately had better outcomes. Now, I don't want this to come across as a deterrent. If you haven't had genetic testing, we really consider, right, while sooner may be better than later, later is significantly better than never. And undergoing genetic testing at any point in the process is beneficial, though this study suggests it may be helpful to do it really close to diagnosis. But again, getting it later is better than never. And so if you haven't had genetic testing, seeking those resources is something we would highly recommend. So I want to talk about the other cancer monitoring. So as Dr. Fishbein talks about in her webinar, and as you saw in the slide a few minutes ago, genetic mutations are often associated with multiple types of tumors. If it's von Hippel-Lindau, we know there's an increased risk for spine and eye retinal tumors. If it's the SDH genes, we know there can be increased risk for kidney cancer. And there's lots of different tumors that we're looking for, often associated with genetic mutations. So establishing care with a high-risk clinic can ensure that you have that appropriate screening. And I'll be talking more about high-risk clinics later on. So I want to just give two examples here about how we change screening when someone has a genetic mutation. Here on the top, you'll see an example. These are the guidelines that came out a few years ago from a consensus group about what to do if somebody has a genetic mutation in the SDH genes. And below, you'll see the guidelines for von Hippel-Lindau, which is another condition associated with pheochromocytoma. Now here you'll see a little bit of difference, right? In the top one, you'll see whole body imaging is recommended starting at age 6 to 8 every few years with annual biochemical testing, whether that's plasma or urine. And in the right, on the bottom, you'll see that they start at different ages and there's different modes of screening. So here for VHL, we start things at less than age 5, 11, 15, and we adjust kind of throughout the lifespan with different imaging, whether that's brain or abdominal. And so I think it's really important to note that the recommendations for what you need differ by condition and differ by your individual history. Sometimes patients will have tumors that we don't actually go in and resect. We watch them because of where they are or because they may not be secreting hormones. There can be a number of reasons that we watch tumors rather than take them out. But if we're watching a tumor, then the every 2-year rule isn't necessarily going to apply to that patient. And so talking with your team and knowing that these are general recommendations, but our goal as genetics care teams is to make sure that we're identifying and tailoring that care treatment to you and your individual history and condition. I want to just share another brief story. In this case, it's a study about why we think screening for other tumors is important. And that's because we just actually published a recent study showing that proactive and regular screening finds tumors before symptoms. So this is a collaboration between Huntsman, University of Colorado, University of Pennsylvania, and University of Michigan, where we studied 263 individuals with SDH mutations. I use SDHX to reference SDHA, B, C, D, and SDHAF2. They had just under 500 imaging scans total, and we found that of those 263, about 17% of them had SDH-related tumors, suggesting that there is benefit to this screening. We also took a look at the biochemical testing that can be the blood and or urine. This was not sufficient as standalone screening. It couldn't detect tumors necessarily. And part of that is because not all paragangliomas are going to secrete hormones that could be caught in that biochemical testing. Importantly, of the patients who had SDH-related tumors, we found 83% of them on their baseline screen. And I want to just focus on this aspect that while screening is very important, starting the process, when we think about I have a mutation and now what, starting the process is one of the most important things because we know that when we find tumors, we often find them on that baseline screen. Now, if we apply this research and to other hereditary conditions, there are lots of studies in the field showing that there's a benefit to early tumor detection as far as long-term outcomes. And so again, starting screening and maintaining screening, but especially starting screening is essential when we think about what's next in having recently been diagnosed with a genetic mutation. The last aspect of this then is family. So we know that first-degree relatives, children, siblings, and parents have a 50% chance of inheriting the same genetic mutation, and therefore they would benefit from genetic testing. I want to walk through this 50%. So if we go back to that idea of genes before, we talked about each person has 2 copies of each gene in their body, right? That recipe being the gene. And their job is normally to prevent the development of tumors. So when somebody has a mutation, it's typically only in 1 copy of that gene. So if we think about the recipe idea, they have 2 copies of each recipe. One has a misspelling and one does not. And so we know that when we are testing family members, we're looking to see which copy of that recipe or which copy of that gene that they inherited. And this is what we call autosomal dominant. And because there's 2 options, one kind of copy that has the correct spelling and one that has the misspelling or the mutation in it, family members then have a 50-50 chance of what they inherit from other family. And again, if people have a mutation in 1 copy of a gene, then they have that increased risk for tumor, but it doesn't guarantee that they'll necessarily develop tumors. With all good things, there are always exceptions. And so I want to just talk really briefly about a few quick examples of exceptions when it comes to this 50-50 rule. The primary one is in the SDHD gene. So when we are teaching our genetic counseling students, we talk about SDHD for dad. And the reason why we do that is because if somebody has an SDHD mutation, they have a 50% chance of having the mutation. However, they only have increased risks for tumors if that mutation is inherited from their dad. So if we think about these 2 scenarios, if I have a patient who is getting genetic testing, she has an SDHD mutation that she inherited from mom, she's a carrier and her family has a 50% chance to inherit that mutation, but she doesn't necessarily have increased tumor risk. So while she still has a mutation, we don't believe that she necessarily has greatly increased risks for Pheo. On the other hand, if I have another patient also coming in for genetic testing who inherited this genetic change from dad, they are also an SDHD mutation carrier, similar to the first patient, but they do have an increased risk for paragangliomas because that mutation came from dad. And so this is one little difference in the SDH genes for SDHD rather than the others. While autosomal dominant inheritance is the mechanism, so everybody has a 50-50 chance of inheriting the mutation, the tumor risk is typically determined by who that mutation is inherited from. I also want to note, we've talked a lot about people with 1 mutation in a gene, but it is possible for people to have mutations in both copies of their SDHA gene. And this is a condition that we call Lee syndrome. And because they have mutations in both copies of their gene, this is called an autosomal recessive condition. This is typically a neurological disorder with some loss of movement control and mental capacity. And we see this fairly early on in the lifespan. So it's not necessarily one that we work people up for, but we know can happen if somebody inherits 2 copies of non-working SDHA genes. And important to note that if you are someone who only has 1 copy that's not working of the SDHA gene, we don't believe there's risk for Lee syndrome, only this risk for kind of the tumors we see in the SDH spectrum. But important to note that if a partner had an SDHA gene, future children could have increased risk for Lee syndrome. And lastly, some of the genes, we see what we call de novo mutations, where the mutation is new in an individual. And so we sometimes see people where they are the first person in their family to have a mutation. Now, we still test family because you can't prove something is a de novo mutation until you actually rule out that other family members are negative. But it's important to note that this isn't necessary, while it still shows autosomal dominant inheritance, so children would be at increased risk, de novo mutations do happen where someone is the first in their family to have this genetic mutation. Now, you may be wondering, okay, she sold me. How do I get my family members tested? And I recommend talking with the person who found your mutation to see how we can test family. In the day and age of COVID, there are lots of telehealth and other ways for us to test family. I do want to note that there are some limitations based on licensure for out-of-state family members. So here in Utah, I'm able to see people from certain other states, but not other states like California, where I don't necessarily have licensure to be able to see those people for genetic counseling if they're in California. And so just noting and really talking with that person, knowing if you have family that's from a wide range across the country, you may want to use a resource I'm going to talk about in a second to help find a genetic resource near you. The genetic testing process is typically using blood or saliva. Because there's a known genetic mutation in the family, it's often covered by insurance. And some labs offer free family testing for 90 to 150 days. Your genetics team will likely have talked with you about this, and so we encourage you to talk with family to get tested early, especially if we're able to offer free testing. I want to just clarify a quick difference, right? While often covered by insurance, this free family testing is run just by the lab without cost. And they do not bill insurance. So in a lot of cases, genetic testing is affordable and accessible regardless of when it's done. But some people like to take advantage of that service offered by the lab. I also want to just note that if you are looking for a genetic counselor near you, this is one of my favorite websites called findageneticcounselor.com. Here you put in your zip code and the specialty type you're looking for is cancer. And you can then specify for in-person versus telehealth to find somebody near you. Now, I know we talked about this before, but I would be remiss if I didn't just put in a quick plug for what you can expect at a genetic counseling visit. So our role as genetic counselors is to help patients understand and adapt to diagnoses. And so our role is for genetic diagnoses. So helping understand your goals for the visit, getting a little bit more information about your medical and family history, and walking through some of the things we've talked about, right? What does it mean to have hereditary risk for Pheo? What does genetic testing entail, and how does this impact you and family moving forward? This is a lot of the conversation that happens in our genetic counseling visits when we're thinking about doing genetic testing for a known family mutation. And then, of course, making a plan for follow-up is important. I've included a link at the bottom if you're interested in learning more about genetic counselors. This also includes the link to finding a genetic counselor near you. So what happens if a family member tests positive? We're back at the scenario we talked about before, right? We do recommend that screening is important. It doesn't really matter whether they've had a Pheo before or any other kind of tumor. If we know that there could be increased risks for tumors down the road, we want to make sure family members are getting screened. And it's really important to establish care with a team that has Pheo and or genetic experience. So I recommend calling your local genetics clinic and asking who they refer patients to. Or starting in 2021, Pheo Alliance will be launching their directory for you to be able to find people who have been identified to have Pheo experience and different centers that can offer comprehensive care. I'm including below just an example of kind of what it looks like and why we think it's beneficial to be with a team that has experience. This is just one of our flow sheets that helps us understand if a patient has a tumor, where do they go? How do we facilitate genetic testing? And what does that flow really look like for them in a way that's comprehensive and streamlined? And so this is just one example of what teams do. I'm obviously biased. This is our example, but lots of teams that have Pheo experience have a similar process, and establishing care with them can ensure streamlined and comprehensive care. People sometimes ask about when we start testing family. And as you saw in the recommendations, the ages really change based on the condition. And so it's important to start to do genetic testing before screening begins. This can be as early as age 1 for patients with von Hippel-Lindau, as late as about 8 to 10 for patients with SDH, and anywhere in between. So talking with your team about when's the right time to test children can be really important. And notably knowing that the goal is to do testing in children before screening begins. And we'll talk a little bit about how to talk with children about genetic testing in just a second. Sometimes people also ask, is there a way to know if my child will have the mutation before or while I'm pregnant? There are options like pre-implantation genetic diagnosis, where a couple undergoes IVF and then they screen the embryos that do and do not have the mutation and only implant those that do not have the mutation. So these do exist prior to pregnancy. However, I would encourage you to talk with your care team about seeing reproductive endocrinology to discuss this further. If you are pregnant, it's important to note that while there are a number of genetic screens, they often will not include testing for something like an SDH mutation. And so being clear and talking with your care team about whether prenatal genetic counseling might be an option for you can be beneficial, because they may be able to help facilitate if you're looking for mutation testing during pregnancy. Although this often typically isn't done unless there's consideration for changes to management during the pregnancy. I've talked about this a little bit before, but this is a question I get really often, whether testing positive or having a mutation means that you'll have a Pheo or will get a tumor. And the answer is no. So I'm just using the SDH genes again as an example because it's kind of a lot of genes that are associated with Pheo. But as you saw before, there are many conditions to be talked about. Here you'll notice that never on this list is the number 100, right? None of these numbers are 100%. In fact, if you look at SDHA, most people with an SDHA mutation will never develop tumors, because if 5 to 10% of people with SDHA mutations will develop tumors, that means over 90% of people with SDHA mutations will not. And so really keeping that in perspective, that none of these are 100%, and that it's important for us to check regardless of the number, because our goal here is to identify tumors before symptoms. Once in a while, patients will come in and they'll feel really frustrated, right? They've gone through this screening process. They're walking through this screening. They're seeing us, right? They have a few extra doctor visits and we don't find anything because their screening comes back negative. And I often tell patients, in my eyes, that's the best case scenario. If we spend our whole life looking for something, it's worth it, because in some people, we will find a tumor. We know that there's that increased risk, but in others who never have one, it's better that we were safe than sorry, because we want to make sure we find these tumors before symptoms occur as our best case scenario. I'm going to spend the last few minutes before we open up for questions just highlighting some common challenges that I see patients experience when they have a new genetic diagnosis or when they're told they have a mutation. It can be a challenge to find a care team to start screening. You may currently have a tumor diagnosis, so now there's almost a second diagnosis to handle. You can have the stress of talking with family about the diagnosis, and now they need to get tested. All of these things kind of add up, especially right after a new diagnosis. In addition to that, sometimes our patients feel guilt related to family members inheriting a mutation that you have. And I'm going to talk about this in just a second. I highlighted this before, but how do we explain genetic testing to minor children? That can be a big challenge. And then in addition, I know we talk about this all the time, and yesterday was Net Cancer Day, but oftentimes we feel as if no one understands because of the rare nature of this condition. It's not like we can walk into a store and find somebody who necessarily knows what we're going through, whereas in other conditions that are more common, it might not be unreasonable that somebody you talk to in the grocery aisle, not nowadays, but somebody you talk to in the grocery aisle, right, has that commonality with you. So the rare nature of the condition can make it challenging as well. I want to just talk about a few kind of strategies and solutions. And as we've talked about, this is a two-parter, so we'll be talking much more about this in January. But I really encourage you to talk with a person who told you about your mutation. Is there a care team that they recommend? How do they talk to children? And how do they help you prioritize your next steps, right? If you're trying to balance treatment, other cancer screening, family needs, that can be a lot to juggle, and they can be a really great resource to look at your individual scenario and help figure out how we do steps 1, 2, and 3 instead of feeling like it's all a part of step 1. When I talk with children about genetic testing, sometimes we use family members who have had a tumor as an example, and we say, remember when so-and-so went to the doctor and the doctor helped them feel better? We want to make sure we're going to do testing to see if we need to, have you see the doctor to make sure that you're healthy, right? A little bit of a different frame. We're not telling them necessarily about the tumor themselves, but we're giving them the resources to understand, I might have to go see additional doctors and we might have to do extra screening. And when we talk about imaging, I'll often talk to kids about, we're going to take pictures of your body. If there's a family member, I'll show them pictures of the family member who's there and has given, consent for these to be pulled up. We'll show them, look at what dad's body looks like. There's the heart and the lungs, and help them understand what they're really going to be experiencing. We also think about how we've coped with tough news in the past, or news that made you feel guilty. I'm going to use 2020 as an example, right? Everybody has different coping mechanisms, whether it's writing or therapy or sharing with friends or just having a good cry every few weeks to kind of let those emotions out. How you cope with that to not only process but move forward can be applied to this scenario as well. And so thinking about ways you've coped with tough news in the past is really important. And it maybe we're seeing if your care team has a psychologist that can help meet and really walk through this process. Here at Huntsman, we have a psychologist who specializes in high-risk conditions, and she's an essential part of our process when patients have a new mutation to help them understand how they're coping and apply previous coping mechanisms to their kind of new diagnosis. I also just want to note that in regards to guilt, we often get a few comments about, I feel terrible that I passed this on. But in reality, as we talked about, almost all of these are inherited, and they've been inherited for a long time. We just didn't have the technology and the knowledge to know it beforehand. And so there's no way that we could have known in advance that somebody had this risk or had this kind of concern that we needed to be looking at. And so while guilt can be really challenging, I think it's really helpful to think about kind of the way in which technology has evolved, and the fact and the benefit we're able to find it now so that we can be proactive for others. Less so than something that we passed on that's negative, something that we can turn into a positive. Now that we know, we can be better about screening and better about early detection. And then Catherine already talked about some of the resources through Pheo Alliance, but I encourage you to use them and the care team to get connected. Would attending monthly calls help? Does your care team have people in the area you could meet up with? We follow a lot of SDH patients here or patients with Pheo and often will connect them with somebody else in the area pre-COVID to be able for them to connect with one another. I want to just highlight the last kind of 60 seconds about common challenges related to screening. So often, before we get to questions, we're not done in 60 seconds. So oftentimes we think about fitting screening into our busy lives, managing the demands of multiple screenings, especially if one family member is in March, but you're in October. There can be stress related to the finances of this and the anxiety, right? Stress leading up to March. Okay, now it's October. Now there's stress leading up to my child's screening. And we see people sometimes get more anxious around the time of their screening that's due, and also about what it means to explain screening to minor children. I've talked a little bit about this, so I'm actually going to start from the bottom up in how we talk with children, right? Thinking about what do we need to do to keep them healthy? How do we take pictures of their body, right? We're not using the words tumor or paraganglioma until they're older. We're really helping them understand this change in a way that's accessible to them. But importantly, when we think about screening barriers, we want to identify what those are and figure out what's the hardest. If you were to prioritize of that list, what's hardest for you? And feel comfortable sharing that with each other and your care team so we can help you figure out how to prioritize. We also want to think about what's doable or manageable. So if all of the kids are at different times, is it better for us to get them all on the same summer schedule? Or we have had a patient, she was a teacher and her scans almost always happened in the early fall. And that was really stressful because it always coincided with the start of the school year. And so we just moved it to a different time frame, not by a ton, right? But figured out a schedule that would work for her to reduce anxiety and keep it memorable. We also talk about attaching screenings to an event. I don't think people ever want to think about a holiday or a birthday or those kinds of things, but I think those happen. And something that happens every year is a great thing to attach those screenings to. So whatever memory it may be that kind of sparks that reminder, or a Google Calendar reminder, whatever it may be, attaching screenings to an event is another way that patients can use to keep on top of screenings. And we're going to be talking, as I mentioned, significantly more about this in January. How do I talk with family? How do I walk through these things and address personal and family dynamics? And how do I talk with children, not only when they're young, but also what happens when my teenagers become adults and it's time for them to think about screening as well and taking kind of ownership of their own care. So those are just some of the things we'll be talking about in January. I've included my email address if there are any questions that you have that come later on down the road. I'm also active on Twitter with this handle here if you have questions in that way. But in this realm, I will kind of pause and turn it over to Catherine to let us know what questions have come in.
Thank you, Samantha. Okay, first up, could you provide important points when explaining the genetic mutation SDHB to one's family?
Yeah, I think this is a phenomenal question. So I've talked a little bit about how we talk about testing, how we talk to family, but I think it's really important if I go back to this idea, I'm going to just skip back a few slides if it will let me. If we talk about this idea of risk, right? And one of the ways that I like to talk about risk is really thinking about what do those numbers look like, but also flipping them, right? So if we think about SDHB, right, we know that there can be about a 20 to 40% lifetime risk, depending on where you look. The research is kind of widely varying, right? But if we think about having a 20 to 40% risk for tumors, that means that on the flip side, right, there is a 60 to 80% chance risk that somebody will never develop tumors. And so thinking about, okay, what does that mean? How do I analogize that to other things? right? In this scenario, you could say, okay, if I put 3 people in a room who all have SDHB mutations, one of them might develop a tumor, but it's important for us to screen everyone to be able to make sure that we find the one. Similarly with SDHB, we know that there can be a slightly increased risk for metastatic or more aggressive paragangliomas. And so in that setting, right, we want to talk about, okay, just because someone gets a tumor, again, doesn't mean it's going to be metastatic. In fact, based on these numbers, a majority of them aren't. And so we often talk about the framing, which is flipping the numbers to think about how we talk with family. I also think it can be really helpful to kind of partner with your care team to kind of talk about how they describe it. And really important to think about that family members who have had a tumor diagnosis are going to have a little bit of a different lens than their family might, right? Everybody going through a personal experience is going to be different than those who watched a family member go through an experience. It's going to be different than someone who found out they had a mutation but haven't ever seen somebody with this tumor. And so really thinking about, okay, what if I put myself in each of those shoes, how would I talk about it? How might it be different? And using some of those conversations to help frame risk for family would just be a few suggestions for thinking about how to talk with family.
Great, thank you. Okay, our next question was, what is the difference between having an SDH mutation versus a RET C634 mutation? It was explained that a Pheo is a result of this mutation and related to MEN2A diagnosis.
Yeah, definitely. So I am just going to talk really briefly, less about the exact kind of the Pheo example, but I'm going to talk a little bit broadly about the differences in mutations. So if we go back to that recipe analysis, the SDHA gene is one recipe, the SDHB gene is another recipe, the RET gene is its own recipe or gene, the VHL gene is its own recipe or gene, and all of these put us at increased risks for pheochromocytomas, and some of them also have increased risk for paragangliomas, which are, again, the tumors that occur outside of the adrenal glands. So in this scenario, the biggest difference between them is honestly the type of tumors that we see associated. And this, I think, actually it looks like there was another question about paraganglioma tumors versus potential cancer tumors. So I'll kind of wrap it all up because every gene is different in the risks that they incur. So when we think about the SDH genes, and I'll just give this kind of as an example, we know that can be associated with the Pheopara, but also the gastrointestinal stromal tumors and kidney cancers. Whereas if I think about VHL, we know that those patients have an increased risk for brain tumors, spine, eye, kidney, and then some cysts in the pancreas in addition, pancreas and kidneys, in addition to the pheochromocytoma. And so similarly, MEN2A has a different presentation to this. And so the difference is not necessarily between the mutations, it's between the gene. And so the genes that I'm talking about here are just examples, but you could take all of this information and apply it to an MEN2A diagnosis and use the tumors that are associated with the MEN condition to think about what we need to do screening for. Unfortunately, there are so many different types of genes that are associated with these. And because there's been that webinar that existed before, we're not going to go into too much of the nitty-gritty between them. But yes, it would make sense that was related to that mutation, and it would be different in its presentation and other tumor risk. And so to speak just to the one about potential cancer tumors, I think it's important to note that a majority of paragangliomas, Pheopara, are benign. They do have the potential to be malignant or metastatic, and in which case we would consider them to be cancerous. And so when I talk about risk for tumors, I'm talking pretty broadly because a majority of them are benign. But it is important to note that in some of these conditions, as I mentioned, right, SDH kidney cancer, we also see that in VHL. We can see risks for thyroid cancer in some of the MEN conditions. Those are cancer tumors that we would want to do additional screening for as well. So I'm talking pretty broadly because every gene is different.
Thanks. The next question is there a way to do genetic testing anonymously so it wouldn't be on a permanent EMR?
Yeah, that's a great question. Not really. So the way that genetic tests, so it's a little bit complicated. So the way that genetic testing is done, I think oftentimes, so let me talk about a few things. Oftentimes people ask that question because they're worried about insurance finding out or any kind of discrimination. And we have a law in place. It's been in place for over a decade now. It's not related to any of the kind of current healthcare conversations that are happening. And it's called the Genetic Information Non-Discrimination Act. And what GINA does is essentially prevents your employers from hiring, firing, promoting, or demoting based on your genetic testing status. And so that means it provides kind of employment discrimination, but it also provides insurance discrimination. So if we think about genetic testing and having a mutation, that can't necessarily be used as a pre-existing condition from your insurance's perspective. It can't be a reason that they drop you or change your premium necessarily. Now, that's a little bit less relevant because we don't use pre-existing conditions as much nowadays, but I think there's always question as to whether or not that will stay. And so for now, even if that went away, genetic testing would not be considered a pre-existing condition in that realm. And so I think that may help alleviate some of the concern about doing it privately. But I think the reality is that if that testing comes back positive, you're going to need, like, we're going to need to do screening. We're going to need to do things to be proactive and preventative. And that is going to need to be an electronic medical record that is going to need to be worked through with a physician. And right now, a majority of this genetic testing, almost all of the genetic testing that we do for this is currently done by a physician or somebody that has to sign off. And so there is a medical liability aspect on their end that requires them to be able to document this and note that they've seen you and ordered this testing. So the answer is it's very rare. It doesn't really happen in hospital settings. There are some times that people can have genetic testing done without, through a genetic testing lab. But it's very rare. And even in those settings, they still authorize it through a physician. And so it is documented somewhere in an EMR, though the location of that EMR may not be your actual institution. So we honestly don't really recommend it because we're trying to get that care and we have those protections in place. And it's not really feasible to do.
Thanks. That was actually very interesting.
Yeah.
Next question was, if someone was tested years ago and shown to have no genetic mutation, should they get tested again?
Yeah, this is one of my favorite questions, and it's also one of the hardest. So in this realm, when we think about kind of when to test, we used to only test, even like 10, 12 years ago, we used to only test for SDHB, C, and D. If we go back to the slide where we think about that timeline, that can be, I'm not going to go all the way back. My slides are being a little wonky, but if we think about that timeline, we used to just test for SDHB, C, and D. And so in that realm, there are other genes. There are SDH-related genes. There are other genes related to paragangliomas and Pheos. Right now, we test for about 14 to 16 genes on a multi-gene panel. And so if you're someone who's had probably 5 or less genes tested, it probably would be beneficial to go back and have additional genetic testing. If you're someone who's had 12 or 13 genes tested, it might be beneficial to wait and check in with your genetics team to see when it might be helpful to test again. We're really looking for that threshold of utility. And we know based on research, there may be as high as 25 genes associated with paragangliomas and Pheos, but we don't necessarily have clinical testing offered for all of them. And so it's hard when somebody is kind of in that 10 to 12 range. We may be more beneficial to wait until we get closer to that 20 plus gene range than we are to just go through and do 14 to 16 genes, because the testing coverage, insurance may not want to cover just for a few extra genes. So I would say if you've had kind of 5 or less genes tested for, it would be beneficial to think about undergoing testing again. And if you're somewhere in that 5 to 12 range, you could check in with your team, but it's likely that we would wait because most people, they either have 1 to 3 genes tested or they had 10 to 12. And if you're in the 1 to 3 genes, it's definitely reasonable. There are many more genes that we know of right now. And if you're in the 10 to 12, it's probably best to wait while the research catches up to identify more genes that we can offer clinical testing for.
Thank you. The next question is, I have a 5-year-old who was just diagnosed with SDHB. Your slide suggested screening starting between the ages of 6 to 8. I'm confused about whether that means I should start at age 6 or
age 8. Yes.
yes.
This is a common question. And while I was not on the panel that made these decisions, it's one we talk about often in our team and with the other kind of my colleagues across the country. There isn't a good answer to this. A lot of it is really patient specific and data specific. So when we think about screening, we select ages because we look at the age of people who were diagnosed with paragangliomas or Pheos, and we look to see kind of where the youngest one was. And our goal for screening is not necessarily to catch every, is not that, I mean, we want to catch as many tumors as possible, but we need to do that in a way that makes sense for you and that we're not bringing someone in every month to get checked, because the likelihood of us finding something, given how slow these tumors grow, that's not really going to be beneficial to the patient or kind of to that screening process. And so screening mechanisms really think about, okay, when does screening kind of benefit the most number of people? When were the earliest stages of diagnosis? When do we start? And so we often, actually here at Huntsman, we typically just start with the biochemical testing at younger ages, and we're really thorough about our blood pressure checks and really thorough neck exams, because we know that for the tumors that, even if they're growing slowly, we want to start that process because those are the things that could cue us that there is a tumor. Now, again, not all tumors secrete hormones. They could be in other areas, but they do grow very slowly. And so as long as the patient isn't having any symptoms and they're having normal blood pressure and normal blood work, then we sometimes start the imaging part on the later end of that, even if we start the biochemical testing. And so your confusion is actually totally valid because there is a range. And I would encourage you to talk with your team about what they recommend. There are consensus guidelines, and I think they help us determine when to start. But your care team is going to be the best resource to help process what those guidelines mean to you in particular, and how they use that data, how the team used that data to make those recommendations can then be applied to your specific scenario. So I would say the answer is yes, it's confusing, and I don't have a great answer, but I would encourage you to talk with your care team.
Thank you. Okay, the next one is, I face challenges in connecting patients to resources for imaging and support. My local hospital doesn't have any protocols for screening patients. If I have no local resources, how do you suggest I start?
Yeah, that is a fantastic question. And I'm actually going to recommend the Pheo Para Alliance as a really great place to start because they're so well connected with a number of clinicians and researchers across the country. But I also know that it's common that patients don't always have something local or resources that are local. And so Pheo Para Alliance can be kind of one place to start because they may have an ability to connect you with somebody in your area. They may have resources that can be beneficial. I know they have brochures and things about what these tumors are and the genetics behind them. But I would think about the other group I would think about would be to see if there is a local genetics clinic near you. They often, we see patients with mutations related to parapheo quite often. And so they might know kind of who they recommend people go to. That may be an endocrinologist or an oncologist or a genetics clinic. It can be kind of highly differing, but I would kind of leverage this community and this organization in order to find those. And it looks like they're kind of including the email address for that on local resources. But I think this directory for care centers is going to be really helpful. Because I think sometimes people feel like I don't have one local, but you may have one not exactly local, but within drivable distance. And we have a center associated with the VHL associated center, and we have patients come, from 4 to 6 hours away, but at least they know when they come in, they've got like a streamlined place where people have a lot of expertise in VHL. And so there can be kind of lots of resources to find things locally, and then also potential resources coming down the pipeline to help find things that may be just outside a local and require a little bit of a drive, but allow you to make sure you're with a comprehensive care team.
Thank you. The next one says, I was tested 4 years ago after my brother had a paraganglioma. 3 out of 4 of us siblings have SDHB. Would you also recommend cousins to be tested, even if their parents haven't gotten testing?
Yes. Oh, that's a fantastic question. So the answer is yes-ish. So I think they mentioned, right, the brother was positive.
Yes.
Okay. So in that scenario, we would recommend cousins get tested if there aren't living relatives in between. So in there, right, between you and a cousin, you have your parents and their parents who are brother or sister to each other. And so if they are not living or not interested in getting tested, then we would recommend that cousins get tested. One challenge can be if there aren't relatives on either side kind of in between, then you may do quite a bit of testing in order to know who also has that risk. Because a cousin, unlike your immediate relatives, a cousin has a 12.5% chance, 13-ish, of having that same genetic change. And so it's likely you may end up with a number of negative cousins until you find a positive. And if you're testing both maternal and paternal, right, one side of that family probably doesn't need that testing necessarily. And so starting, if it's possible to start with parents, if they're not interested, thinking about starting with aunts and uncles. If they're not interested or available, then cousins would be the best option. But you'll end up doing a number of tests to find them. Still important, right? But if we're able, to cut down on the number of tests that we need to do, then that's kind of better for the system overall. It helps us walk through things more methodically.
Interesting. The next question is, how do I convince siblings to be tested?
Oh, convincing is one of the most challenging words in genetics. The answer is you can't, right? I mean, there are things that you can say and information that you can share, but at the end of the day, we can only really have control over ourselves. And this is something we see quite often in our families, right? That you are coming in and getting screening, but that family is not interested. And what I would say is that it doesn't hurt to talk about it, right? Thanksgiving is actually National Family History Day. So we're coming up on a great time to chat about it. But we also don't want to push it so hard that it impacts the relationship we have with our relatives. There are often a number of things that bring people in, and the rhyme or reason for why family changed their mind is highly variable. I hate to say it, and I'll kind of knock on wood, right? Sometimes people decide to get tested when another family member has a tumor and they realize, like, wow, that could be me. Or they kind of are in denial in the beginning. It can be a hard thing to process to see a family member with a tumor, and knowing that they could also have risk for that tumor. And so the patient needs to move through that denial process, to really be ready. And so I think continuing to keep the lines of communication open is really beneficial in that setting, and discussing it, but also knowing that really our locus of control is within ourselves. And that is a really challenging aspect that we will be talking about in January as well.
Thank you. The next one relates to an FH mutation.
Mhm.
It says, I have an FH mutation of unknown significance. The genetic counselor has said there's no action to take, but I'm hearing otherwise.
Yeah. So, as I mentioned, the unknown significance kind of goes back to that diagram when we talked about uncertain significance. We know that over 90% of the time, uncertain significance changes turn out to be benign. They are not later considered mutations. And I think we also are starting to learn more about FH. So we normally think about an association with uterine fibroids and kidney cancer and skin kind of findings. But we're starting to think that maybe they could have an association with Pheo as well, though that isn't really as fleshed out in the literature as some of the other genes that we know are associated with Pheo. And so that's probably where some of this is coming from, is that we kind of have to separate the two, right? There's some conversation as to what if we need to be doing Pheo screening in patients with FH mutations. And there's also this uncertain result. And from an uncertain result perspective, we don't have any reason to take action because we know most of the time it turns out to be negative. On the other hand, there's always chatter when we hear these uncertain results, right? Could they be related? And could I be in the small population of people who end up having a positive test result? And so this is a challenge that people go through, and it's entirely possible for both to be accurate. I don't want to speak to the kind of immediate situation, but I guess my point would be that the uncertain results, very similar to those unknowns, typically does become a negative. And so we never say always or never in genetics, but in a majority, almost all settings, we typically wouldn't take action in uncertain results, regardless of the gene.
Okay. The next one, if I have already been diagnosed with Pheo and I have a genetic mutation, does that mean there's a higher chance for the tumor to reoccur? And if it does reoccur, does having the genetic mutation mean a higher chance for metastasize?
Ooh, that is a great question. It is a highly variable question that kind of depends on the person, the way it was treated, the gene, the present. I mean, there's so many different factors that go into this. And so I'm only going to speak kind of about the things that we know in relation to genetics kind of as a whole rather than to an individual scenario. So when we think about recurrence, that is often more based on kind of how it was resected. Were they able to get everything? Had it maybe already spread to other places? And so it's like recurring there, maybe some tissue was left over. It's not typically something that we think about when we think about, genetics, because in genetics, we're typically thinking about a second tumor occurring. When we think about someone having a genetic mutation, we think they have a higher chance of having a second Pheo. But the genetic testing related to metastases and all of that is typically based on the gene itself. So as I mentioned, when people have a mutation in the SDHB genes, we know there can be a higher likelihood for malignant or metastatic tumors compared to some of the other genes. But that doesn't necessarily exclude other genes and people who have tumors related to other genes from also being metastatic. So I'm not really specifically answering that question, but more so kind of speaking to the generalization. We think about metastasis and recurrence and risk for a second tumor as kind of individual things that I would recommend you talk with your provider about.
All right, thank you. I think we coming up on it, so I think we probably only have one more question we can ask. So the last question would be, any suggestions on how to handle or speak to a family member who did metastasize? We're not getting the best care for him, or return calls to assist. Any suggestions? How do you handle, I guess, how would you handle a family member that might be struggling?
Yeah, this is a big challenge. And I don't mean it's a challenge because people don't pick up the phone, but I think it's really hard to be a family member watching somebody go through something and feeling helpless and like we're not getting what we need. And the things that I would recommend would be, to be as supportive and to think about ways that you can help. I think using Pheo Alliance to think about if there are other centers in the area that may be able to help, or thinking about what the resources look like in the area is kind of one way. And the best way to really be a support is to be an advocate and an ear, right? How do I help advocate for what my family member needs? And how do I help be there when they're struggling? And acknowledging that may also be struggling yourself. It's not easy to watch family go through this. And so if we think about those coping mechanisms, right, what works for you? Is that is that showing up to the family member's house, depending on your COVID restrictions, right? Is that showing up to the family member's house with food and a board game to keep their mind off it for the night? Is that finding a therapist that they can go to or that you can go to process that? Is that reaching out to Pheo Alliance to see what those options are in the area? Thinking about how you cope with things in the past, right? Do I go look for more information from other people? Do I really cling tighter to my support system and help them, have us go through it as a group? Am I somebody who just needs, I use this, right? Like sometimes I just need a good cry to kind of process through, and then I'm ready to move on to the next thing. And so everybody copes differently. But I think acknowledging those emotions and thinking about times you felt that in the past in other settings and applying them there would be a great kind of place to start.
All right. Well, thank you so much, Samantha, for the time that you've spent and your dedication to helping out our community. I would also just like to take a second to thank Progenics again for making the webinar actually possible. This will be uploaded to YouTube and available in a few days. And if this has been very helpful to you, we encourage you to include the Pheo Para Alliance in your end of year giving. You can donate at pheopara.org/donate. And thank you to everyone who attended today. Really appreciate you showing up. And just a reminder that we are Pheo Para Fearless. Thank you again.
Thanks, everyone.